As we approach the end of 2024, it's interesting to reflect on where we are with Crohn's disease and positioning of therapies and principles of management. Clearly it's important that we have a holistic approach with the patient front and center. We need to use effective drugs. We need to use them at the right time and try and get the right drug to the right person. But we need to just remind ourselves that it's inflammation that is the danger signal. We've seen that time and time again. We saw with Profile, of course, not only that early effective therapy with infliximab and azathioprine started as early as day 14 after diagnosis has dramatically better outcomes, but we see it's associated with fewer adverse events. I mean, markedly fewer adverse events than a traditional step-up approach. You get fewer Crohn's flares, you get fewer hospitalizations, you get fewer infections, you get fewer serious infections, and you don't see significant toxicity from the drugs. It's not the drugs that cause the problem, it's the inflammation that causes the problem. And in the last couple of months, we saw two very nice papers from Alex Forgan and colleagues looking at the risks of placebo in patients with inflammatory bowel disease. And there, from all the induction and maintenance randomized controlled data, you see again and again that its harm comes from placebo, not from the effective drugs. So what does that mean for a newly diagnosed Crohn's disease patient? It means that the vast majority of patients should go straight away onto effective therapy. That means a biologic agent. That could mean infliximab plus azathioprine as per Profile, the most evidence-based approach. That could mean adalimumab monotherapy. It has meant more and more in North America, Stelara monotherapy straight up, but now with the P19s becoming available, and particularly with the sequence data, we see more and more risankizumab or Skyrizi in this point. We see it in the markets that are able to use it, a lot of risankizumab first line. I think it's now the most commonly prescribed first line agent in the USA. It's rapidly becoming that in Canada and across other regions of the world where access is less of an issue, such as the Gulf states. When you're later down in lines of therapy, then key questions are when do you optimize a therapy versus when do you switch? I think it's important that we're not burning through therapies. TNF therapies need to be optimized. But I say to people, when you're optimizing, just get on and optimize the drug properly and don't wait too long. So if you're using a treat to target approach, which I hope you are, if you're then monitor and act on the results of the monitoring, then if you're off target, you should optimize the drug if that's an option with a TNF, but double the dose, give it more frequently, optimize the immunosuppressant if that's what you're doing, but don't then wait too long. And if it's not a TNF, switch out of class, and we now have multiple agents to move to. So if you're failing TNF, the data would support moving on to a P19, such as risankizumab over ustekinumab. The data would also support moving to a JAK inhibitor, such as upadacitinib in Crohn's disease. So I think we're getting a long, long way. And certainly in my clinic in Edinburgh, we're seeing more and more patients who are well over time. And if you look at the Edinburgh IBD unit as a whole, you see that where we've treated patients early, we're seeing fewer hospitalizations. We've seen almost halve in the 10 years from 2010 to 2020 for IBD-related issues. We've also seen almost a halving in the rates of surgery for Crohn's disease too. So just a few thoughts about Crohn's disease management as we approach 2025 with multiple effective agents. It matters less which of the effective agents you use. It matters more that you use them, that you don't worry too much about any adverse events. Obviously, we need to be hypervigilant for the patients that are at increased risk. We need to be thoughtful about this. But we must much more remember that it's the inflammation that's the danger signal. That increases the risk of adverse events, such as heart attacks and strokes, infections, venous thromboembolic complications, and all the rest of it. More from me soon. Bye-bye.